Wonderful. Hi, everyone. Thank you for joining us today for a chronic disease management work group. My name is Christy Degner, and I'm a site engagement coordinator for MVC. I look forward to facilitating this work group today. Today's chronic disease management work group will feature a presentation by Kara Neuman and Kathy Bruzewski of MyMichigan Health. Kara has been an RN with MyMichigan Health since February 2000. She started her career as a medical surgical nurse, then moved on as an ER nurse, followed by PACU, and then as an outpatient clinic nurse. Her most recent role with MyMichigan Health was MyMichigan Health, very first transitions of care RN, before recently transitioning to the manager for case management for Midland and Alpena. Kathy has been with MyMichigan Health for 32 years, helping patients and working alongside primary care providers and other members of the healthcare team throughout MyMichigan. Her career began in the CCU or PCU, and after 10 years, she transitioned to the UM Quality Department, where she went on to work for the MidMichigan Health Network as a care manager and worked to complete and receive 2 NCQA certifications in utilization management. She was one of the first 3 care managers in the health system that transitioned to the Ambulatory Care Management program, working in the Family Practice Residency program. In 2022, she transitioned to become the manager of ambulatory clinical services. Her team consists of 16 RN care managers, 1 social worker, and 7 patient care navigators. The team works across 27 MyMichigan Health practices, helping patients to manage their new, chronic, or complex health conditions. Thank you, Kara and Kathy, for being here today. Before you begin your presentation, I have some brief housekeeping items to review. First, this session is being recorded, and the slides and the recording will be shared with attendees following the work group. Next, we will be monitoring the chat throughout the presentation, so feel free to add any questions there. We'll also have some designated time at the end of Kara and Kathy's presentation for a Q&A and discussion. And then lastly, your feedback is very important to us. If you could please complete the post-work group survey in a link that will be provided following the meeting, it would be greatly appreciated. Thank you so much for joining us, and I'll pass it over to Karen and Kathy for their presentation.
Okay, I will share my screen here, just one moment. Can everyone see this?
Not yet.
Okay. How about that?
Coming up now. Yep, looks perfect.
Good. All righty, let me get my screens up here. Well, good morning, and thank you for having us today to talk about our transition of care and the projects we're doing and the education we utilize in our transition of care. I think that we have worked hard to improve our transition over the years, which aligns with our purpose in creating healthy communities and healthy patients together. Thank you for the beautiful introduction. That was very nice. As she indicated, I do govern the nurse care managers and the patient care navigators. Our vision and mission in care management is to transform healthcare together in MyMichigan with the vision to collaborate with patients and providers and communities and population health, really working on the population health, enhancing patient and family experience, and improving clinician experience and helping to lower that cost curve. So all of which supports our patients from the time of discharge until their first appointment and follow-up care. Our strategic areas of focus for transition of care management are high-risk care management and transition of care. With our transition of care, our care managers are strategically assigned. We use a stratification to meet with the most complex and chronic post-discharge. Our teams work at improving readmissions rates for those ambulatory care sensitive conditions. And based on data and information that we receive from ACO, CMS, payer groups, COPD, CHF, diabetes, pneumonia, sepsis, end-stage renal disease. Those are all areas of opportunity at MidMichigan Health to make some improvement. The data indicates we have a lot of potential avoidable costs on inpatient admissions and ED utilization. And we know that individuals with chronic conditions account for about 84% of national healthcare spending in relation to these. So our care management services they serve to manage health and improve quality and reduce cost of care and transition through our transition of care, work, and education. Next slide. So we identify patients' needs at the individual and population levels to effectively manage and plan and coordinate patient care in partnership with the families and patients and their caregivers. Emphasis is placed on supporting patients who are at the highest risk, highest need. We use our risk stratification tool to identify and predict patients with the highest risk. Our current risk stratification model includes the circle elements that you see on the screen, behavioral health conditions, high cost utilization, poorly controlled complex conditions, some payer information. We do not have included SOH, but that is a current project we're working on right now. So we're working with the EPIC team to incorporate SOH variables into our risk stratification scoring by having an auto adjust option when there are two noted SOH positives. So it adjusts the risk score to 40%, and this would place the patient on their care management's reporting daily. It would also trigger a BPA for the clinical staff at the practice level to provide the resource information right then and there, or they can put a referral to our ambulatory social worker if needed as well. But ideally, you would want to meet the patient where they're at and hopefully provide that resource right then and there when the BPA is triggered. We use the EPIC predictive risk model of risk of ED visit or hospital admission. And the care managers follow for the high risk, 40% or greater. So this is our prioritization process for transition of care. The nurse care managers and the patient care navigators pull a list of discharges. We utilize EPIC and the Bamboo patient ping reporting. Our expected outreach follows CMS guidelines. We prioritize TCM workloads through centralized nursing and practice-based RN care managers. High-risk care managers are embedded into the MyMichigan offices, and our centralized nurse care managers are offsite. And lastly, our patient care navigators are all located at or near our 8 ED locations within our organization. So our embedded care managers, they work on high risk and targeted diagnosis. And then our centralized care managers, they work on that medium to high risk patient population of the non-targeted diagnosis. And then lastly, our patient care navigators help out as well in terms of working with the low risk discharges from the 0 to 19% risk stratification. And they also, the centralized and the patient care navigators, the whole team works really good together in terms of even if they're low risk or medium risk, and they identify those needs, they're doing the warm handoffs to the embedded care managers in the practice at the practice level. We abide by CMS guidelines, and the transition of care elements are listed here. This really helps support our standards of practice and provide specific structure and expectations for our care managers and patient care navigators. We have a pretty robust transition of care guidelines that goes through, requirements, who can provide it, the components, medical decision-making, conducting the call-in, specific scripting, especially for those that are new in our program or on our team. So, and it goes into detail, and especially in relation to medical decision making, because we would want them to work collaboratively with the providers to help make sure that we're meeting the criteria for those TCM visits. These are our transition of care templates, and I included these. I know the small print, but I included these here to show you the level of detailed questions that we touch upon with our patients. It was much shorter previously before fall 2022. In fall 2022, as a team, we updated our templates to make them more comprehensive. we're able to capture a lot more information and follow-up details with the patients and help them with their questions regarding the hospitalization and discharge instructions. And so we dive into medication, management, their understanding of why they were hospitalized and their discharge diagnosis and their follow-ups, DME. So it's really detailed. We have the option of putting in referrals to social work or care management. We also dive into ACP, and anything that's pertinent positive always shows up in highlighted bold red, much like physician notes do. From these detailed templates, we then developed an interventions tab to track our findings, which helps to demonstrate our value in the system. As many of you probably know, doing those transition touch points, we find a lot of things with patients in terms of their level of understanding or things that they didn't get or appointments that weren't set up. And so we have this intervention tab that's available there when we do find things. We can pull a report off of it, and then I encourage or engage the care managers and the patient care navigators to take save some of these stories and take them into at the practice level, the provider level meetings, at least quarterly, to speak to what we do and also take in information on our engagement level with their patients in those meetings. It's just all in an effort to increase provider engagement, which is one of our goals for 2024. So it starts right at the frontline level to try to work on these things. And I think we have surveys, and so when we get information back from patients, they seem to appreciate the touch points that we have. And I think it's really because of the detail. The patients are engaged and appreciative. Readmission strategy, all the patients who are readmitted with these diagnoses, COPD, CHF, diabetes, pneumonia, sepsis, end-stage renal disease, they all need to be engaged with care management. And after we thoroughly assess, why readmissions occur, care manager will provide self-management support, education, and plans to overcome the current and future barriers. We talk a lot about symptoms and what to look for on readmissions. We touch base with them weekly for a month. As we know, this is a kind of a critical time frame when we see a lot of readmissions, kind of reinforcing each week the educational elements that we provided the week before to kind of recap and gauge their level of understanding what we gave them last week. And then, a lot of information on what to do when you're having symptoms and who to call. So we capture these readmission cases in relation to our daily EPIC reports, and also, on the Bamboo patient ping, you can utilize the readmission flag to capture these patients so we don't miss anybody. And we have a dot phrase and cover some pretty basic questions in readmissions, really getting down to honing down on their perspective and what was the main cause of the readmission for the hospitalization and providing the self-management support. In relation to readmission strategy, again, SDOH, anybody that has 2 or more positives, we're going to be assessing and working with them right then and there when we're doing the transition to resolve the findings. If needed, if they need additional assistance, we have a great care coordination team in where the care managers or the navigators can refer to the patient care navigator or to the community health workers, pharmacy, behavioral health. We don't have a lot of pharmacy in the ambulatory setting, but we do have a few. And so it's good to have that collaboration and support. In relation to referrals, we're looking at reporting on a daily basis, and we may identify patients, and we have some standing orders and can reach out to the provider to request referrals as well. But we always put in there why the patients identified for care management and areas of focus that we'd like to focus on in a plan of care with the patient. And then afterwards, always circling back and providing that collaboration and updating not only the provider, but the team at the practice level, just to increase our teamwork and also hopefully increase provider engagement. Other referral resources, we do, work collaboratively with the inpatient team, and they provide us with referrals for care management on those targeted diagnoses. And they're really great. We've really improved our connections between the inpatient and the ambulatory world over the last few years. And they are very good about giving us those last minute updates prior to discharge as well. We utilize telematic groups a lot, and that's been kind of a blessing since telematic came to fruition. So we are connecting with them via telematic, and they're connecting with us in groups because, as we know, a lot of the ambulatory care managers are spread over, 2, sometimes 3 practices. So the groups have been really, really beneficial. We also have the transition of care nurse meetings. We look at readmissions as well and have some open dialogue, which Kara will speak to in just a little minute. COPD, as part of the standardized admission and discharge process, care managers will receive referral for COPD patients, and we try to get them, work hard on assessing them and offering onboarding with care management. And both the care managers and the PCNs work to get them in within 7 days of discharge. COPD and CHF, the care manager is available, and we assist with co-management of patients' needs while working with the clinics. The ambulatory care managers, they meet monthly with the CHF clinic RNs in the Midland and the Central region. And so they've been increasing their collaboration, talking about, workflows and patient issues and how to work on process improvement with them. And so they're always looking for those opportunities to engage with our specialty clinics as well. It demonstrates to the patient that we're working together and providing sort of a unified support and education. Kara.
Thank you, Kathy. Good morning, everybody. I'm Kara Neuman, and I'm going to talk a little bit about our transitions of care nurse implementation. And go ahead, you can go to the next slide, Kathy. So what is a transitions of care nurse? Why did we start a transitions of care program? Which patients did we choose to focus on? What does the follow-up process look like? Some of our trending readmission rates with our BPCI chronic disease patients, implementation of readmission discussion huddles, and what are we seeing now? Next slide, please. So what is the transitions of KRN? I was honored to be able to be hired in as our first transitions of care nurse starting in October of 2021. And so I was hired to oversee the care of a patient as they move from one healthcare facility, such as a hospital or nursing home, to another facility or their home. I was able to provide follow-up care for the patient to assure their transition to home is supported by providing chronic disease management and education, reconcile medications, assure follow-up appointments are made, and also to assure that post-acute support, such as home care, is established, and also, most importantly, to empower the patients to manage their own health care. Next slide, please. So why did we start a transitions of care program? When focusing on our high-risk chronic disease patients, especially our CHF, COPD, we realized that our readmission rates were higher for our patients who followed with not only our independent providers, but those patients who did not have a primary care provider, compared with those who followed up with our MyMichigan Health providers. And those patients were being closely monitored by Kathy's team with the Ambulatory Care Management, but we realized there was a large gap in follow-up care for these patients that did not have ambulatory care management. Next slide, please. So we chose to focus on at the time we were involved in a BPCI advanced program. I'm not sure for those of you who are familiar with that. It's a bundled payment for care improvement. And so they were chronic disease patients, and we made sure that we followed these patients for 90 days post-discharge from the hospital. These patients mainly consisted of high risk for readmission diagnoses, including COPD, CHF, pneumonia, sepsis, and renal failure. Next slide, please. How did we identify the patients? We did develop some reports via EPIC. We used a scoring system once they met the diagnosis criteria and were identified as high risk for readmission. If the patient happened to be followed by a Mid-Michigan primary care provider, then I would go ahead and send that referral off to Kathy's team and to that specific ambulatory care manager, just to flag those patients as high risk, meaning that they needed some closer follow-up. If the patient was followed by an independent practice primary care doctor or did not have a primary care doctor, then I would go ahead and add that patient to my list for close follow-up. Next slide, please. What does the process look like? Kind of similar to Kathy's team, patient definitely would be contacted within hopefully 24 to 48 hours post-discharge from the hospital. Sometimes on the weekend or holiday, it would take a little bit longer, but really we'd like to stick within that 24 to 48 hour window. Assure that the patient had a follow-up appointment with either their primary care doctor or specialty clinic within 7 to 10 days post-discharge. We really realized that having eyes on that patient within a week after discharge made a big difference. And for example, if it was a heart failure clinic patient, as long as they were seen, in the heart failure clinic within a week, and then follow up with their primary care doctor after that. We would follow the patient at least weekly for the first 30 days, and then as needed up to 90 days. Each patient follow-up was unique to the needs of the patient. Sometimes it would look like a patient would be called maybe 3 times in the first week. It just really depended on what that patient needed. We try our best to catch all of the things that these patients might need in the hospital, but we do sometimes find out once they're home that they had more needs than we realized. So they sometimes would require a closer follow-up than even once a week. And then we really would try to stick with the unique needs of the patient, because everybody's a little bit different. I would even have patients contact me after that 90 days, which I welcomed, because if they needed that extra support, we were able to provide that. Next slide, please. So trending readmission rates for our BPCI patients, we were working at the time with Signify Health, was a healthcare platform that leverages advanced analytics and technology and nationwide provider networks. And so they were helping us at the time for these high-risk BPCI patients. We started this process in October of 2021. And by May of 2022, we realized that what we were doing was working. Our readmission rate of the followed patients was down to 19.2%. That was actually below both the peer benchmark that was at 27.6%, and actually met the top quartile of Signify Health partners. They were working with several organizations at the time, and it was really nice to see that all of our efforts were really making a difference with these patients. Sepsis, CHF, simple pneumonia, they did represent the top 3 bundles, representing 54% of the patients. Renal failure was also at the top readmission bundle. Of course, those patients are quite sick and hard to keep out of the hospital at times, but we did realize that really what we were doing was truly making a difference with making sure the patients had what they needed at home and the care that they needed to prevent the readmissions. Next slide, please. Another aspect of this program was that we implemented readmission huddles. The readmission huddle process was meant to address and mitigate the identified reason for readmission and initiate longitudinal population health process of care redesign. So we would find out what the patient anchor admission information first, and then discuss specific issues surrounding that readmission, identify all process issues resulting in the readmission, what will we do now for this patient, and what are the takeaways to improve the process of care for all patients. We were able to identify problems that we could take away for all of our patients to look at a system level. Usually, the huddles would consist of myself, Kathy and her team, whoever the ambulatory care manager happened to be following this patient readmitted would come to the huddles to discuss. We also had representation from inpatient case management, Amy Bailey, who is our ACP ACP documentation specialist, and then, some of our post-acute providers, including home care and SNF representation. We really wanted to use this as an opportunity to collaborate on a positive level. Let's take a look. Let's just take a look to see what opportunities we maybe missed and how can we work together to prevent it from happening again. Next slide, please. So what are we doing now? Since the completion of BPCI, we are no longer in that program. We really wanted to continue doing what we were for these chronic disease patients. So we have continued with the transitions of care RN role. I have currently, recently, I guess, been moved into the manager for inpatient case management. So we have since hired a new nurse for the transitions of care role. We changed our focus a bit to focus on mainly COPD, CHF, and pneumonia patients. However, we still adhere to the same practices and procedures. We realized this was working well, and the support provided for these patients was going so well that we wanted to continue this. So we are still continuing to do this today. Next slide, please. And some more of the coordination initiatives to improve the transitions of care role that I just spoke of. We also have throughput coordinators who work very closely with our providers to help with difficult discharges. We have case management assistants who are able to help the inpatient case managers to provide with transportation and referrals, a lot of the aspects that take a lot of time. And a new reporting structure. Kathy and I have been very fortunate to work together over the last couple of years, and we're lucky now to report to the same leader. Excuse me.
Yes, we are. I would agree.
Yeah, so we'll continue this. So I'll let you go from here, Kathy.
Okay, all right. So in relation to readmissions, we have meetings at the practice level for both the nurse care managers and patient care navigators to discuss readmissions. Right. Much like the transition to care nursing, having that open dialogue with different team members to see if there are barriers that we can help the patients with. It's an expectation, and we generally always have key takeaways from these meetings. Telemedic groups, we mentioned that before. Historically, we tried a lot of methods to bridge the inpatient ambulatory world, but telemedic really works. It's improved our connections, and it seems to be the best option currently in our fast-moving healthcare world. Care plan hyperlink development. We've been working on that. So we've been working on specific care plans for readmissions and high ED utilization. So we're working on this hyperlink development that's on our storyboard that will take either specialists or providers or our ER doctors straight to the specific care plan for readmission and high ED utilization, which is nice because sometimes it's difficult to navigate around the Epic platform to find what they need and who's doing what. Monthly town hall meetings have proven very useful. We come together with the Altex, rehabs, SNFs, and talk about, what each other are doing. Those transitions when they go from those facilities or agencies back to their home or community PCP. We're working on building and collaborating with them to improve the collaboration and improve our patient care. We've developed a better perspective for what they do. We understand their workflows a little bit better and their processes a little better. So it's really been a good benefit to have that. And we do that every other month. We all come together in person. And then lastly, we do have some, I didn't put it on here, but I should have, the nurse care managers and patient care navigators have some small shared governance groups in each region, and where they come together and share ideas, and if they're having any difficulties with transition of care or note there's different needs in different regions, they come together and share these ideas, then work on a process to improvement. Bring it back to the whole group at the end of the month and have discussion. And if it needs to be taken to a higher level, then we have we take it to our physician champion or upper leadership. But, you know, an example would be in one of the central regions, they didn't have as much assistance for additional medication assistant programs in that region. So we worked on that to better help our patients when they're transitioning in their care. In terms of education, we've talked about some of the types of education we have, but all of the self-management support you'll see here for all these diagnoses are embedded within our Epic system. We have the traffic light, green, yellow, red zone that many of you are probably familiar with, that we utilize with patients, as well as specific diagnosis type education that are embedded in Epic that we can pull into our notes and walk through with the patient. So we're all being consistent in our care and education. And in our CCM program, we have really nice education booklets, which I'll kind of scroll through those with you in relation to COPD, CHF, diabetes, and those targeted diagnoses. Also been really working on, streamlining our care plans. Last year, we really worked on enhancing our TCM templates and making them more comprehensive. This year, we've been working on our care plans for those targeted diagnoses, with, you know, including specific elements of education for each, and expectations. Provides the structure and standards of practice. We also made sure to include care team conference with providers and to demonstrate our collaboration in those notes and with patients. In 2024, we would really like to, once these are all built and complete, look at the percentage of engagement with these targeted populations by our care plans and can compare them to readmission and utilization, which is more of a more outcome-based information, which is nice to have. And so you can see some of the elements are the same with all of the care plans in terms of demographics, social, some screening information, SDOH, depression, anxiety. We have a summary usually right at the top, always clinical information, signs and symptoms. Education will be different with each one, of course, but there'll be check boxes and drop down calendar for each date that the education is completed. Care team conference and next appointments and action plans all included in all of them. So really hoping this will be beneficial to demonstrate further value with our system and increase engagement with our providers. One of our education booklets, the COPD booklet, I will open that up and have you take a look at it. I'm not going to go through everything in this, but I wanted to kind of scroll through and show you. It's really nicely done. It has a table of contents. There's a lot of information that you can go through with a patient. So when you're working with them in care management, it's not really realistic to go through the whole book in one setting, but you can take segments of it at each visit and go through it with the patient. So it talks about the COPD and it describes what it is, the common risk factors, signs and symptoms, how it's diagnosed, those PFT tests that the patients go for, exacerbations and what to do if your symptoms worsen, and how will I know, you know, simple questions to ask yourself in terms of, are you having an exacerbation? Here you can see our traffic light type of self-management support care plan.
I can't really see inside, Kathy.
You can't what?
I can't see the inside right now.
Oh, you can't?
Mm-mm.
Huh, that's strange. I'm sharing. Well, I will have to forward these. I'm not sure why it's not showing the hyperlink. Well,
I think it's because you're sharing the presentation and not your screen, but I'm more than happy to forward the hyperlink afterwards, or you can share your screen as well, the full screen, but whatever's best for you. I can definitely share the hyperlink afterwards.
I will share this afterwards because I've kind of talked through some of the elements of it. This is the heart failure booklet as well. I like this one. It's very visual. And it walks through similar elements of, disease education, what it is, what symptoms to watch out for, common causes, what you should do on daily tasks, medication management, who to contact. It has also a traffic light care plan. And we also have another one for our helping you live well with diabetes. So these are great tools to have when we're working with them in care management. And, usually we pull a lot of patients, a fair amount of patients in, when we're working with them in our transition of care and in meeting with them at their follow-up appointments with the providers. And it's nice to have these tools that we're all, that we all use so that we're all giving the same information consistently. Measures of success. Well, in terms of measuring success, we continuously look at our hospitalization rates and our readmissions. We use our Tableau reports for those, and we have a transition of care follow-up call report also. So this assesses anybody in the system and the transition who completes transition of care contact. I can also separate it out to nurse care managers, patient care navigators in terms of their two-day follow-up. In relation to timely follow-up with PCP, this report also includes 7-day follow-up and 14-day follow-up, which is nice. So you can kind of gauge where everybody's at in the system with a 7-day and 14-day. And as we continue to increase access and we are developing continuing care clinics, so I'll be anxious to see how the percentages improve with these follow-ups. In relation to high-risk care management, for these targeted diagnosis, I currently can look at our registries to tie into a percentage of engagement. However, like I had mentioned previously, I would really like to kind of track our updated care plans for the targeted diagnosis and compare to the readmission rates and utilization in 2024 as more of an outcome-based type reporting. To reduce avoidable admissions and ED ED costs, we get a lot of that information from our ACO, and we're hoping with our transition of care work and our streamlined care plans that we're going to see improvements in readmissions and in utilization, high utilization, and avoid some of those costs. Care management graduation rates, we do have that. It's included in one of my transition of care reports, and hopefully focus a little bit more on that in 2024. We have kind of revamped our care management program to make it a little more structured and a 90-day program. And so hopefully in 2024, we'll have some more results on graduation rates with patients. We do initially have care management surveys, and it should be a CM, sorry, it was a typo. So those are given out to the patients when they're drawing to the end of our program with care management, and we mail them back for a review. We started those this year, and generally it's been very positive so far from patients, no complaints. And so, but it is really a nice tool to have, because obviously we would want to make changes or improvements if we were, if patients were giving us valuable feedback on the care that they received. And then lastly, we do, in terms of our transition of care and care management, we do have peer auditing tool, and we do that about every other month to kind of keep us accountable and make sure that, again, that we're all providing this standard of care. And so I just want to thank you guys again for allowing us to come and talk. And I guess we would open it up to questions at this time.
Thanks so much, Kara and Kathy. I'm going to remove the spotlight so we can all see each other in gallery view. Does anyone have any questions for Kara or Kathy? There's one comment from Jacqueline Evans. Excellent program. Completely agree. It's really, really impactful that you're doing. Great presentation. I can kickstart us with a question. I guess the first question that I have is, do you, I'm sure you have multiple successful stories, but do you have one success story that particularly stands out to you with a patient that's kind of gone through the transitions of care process, specifically maybe Kara, one that you've worked with, the transitions of care RN that just stands out?
Sure. Yeah, I do. I mean, and really, when the program first started, I have several, but I will use one example. It was a patient who went home. He had a new onset of CHF, and he really had no idea what to do at home and what he could do for himself. He was at the beginning stages. He lived alone. He was not currently happy with his current primary care doctor, so he was struggling getting any support at all. And so I worked with him. He was one of my first patients. And so I talked with him several times in the first week, just the basic knowledge of CHF and what to look for, and, diet and checking your weight, and got him set up with a new primary care doctor, went over medications. And he just, I don't think I can do this, and just to kind of listen to him throughout the program, and the way that he was empowered to take ownership of his own healthcare was amazing to me. He was one of those patients that we continued weekly phone calls for up to 90 days. And he every week expected my phone call. And he said, "Oh, I see you're calling." And I had a smile on my face knowing it was you. And just was happy to tell me all the success that he was having. He had a CHF as a new onset CHF. We all know how difficult that is for patients to get that under control and find the right medications and diet and fluid. And he was a success story. I mean, he was doing well, and he felt that he had a really good handle on it. And he thanked me at the end. He was very thankful for the support, and he said that he felt confident that he could take care of his own issues with the CHF, and also continue with the heart failure clinic and his primary care doctor. So that was just one, and there were so many. And I continue to work closely with the new transitions of care RN now, and she's just amazed herself at how much she's actually able to help, and how receptive these patients are, and just that empowerment of taking ownership of their health.
Absolutely. Thank you so much for sharing. We do have a question in the from Jacqueline Evans. Do you facilitate patient referrals to cardiac and pulmonary rehabilitation?
I think I can speak to
Kathy?
that.
Go ahead, Kathy.
If our care managers, feel that is needed, then yes, we would help facilitate that.
Wonderful. Thanks for the question, Jacqueline. Does anyone have any other questions for Kara or Kathy? I do have one more question. I know that you briefly touched on it about getting started with incorporating those SDOH variables into the EMR.
Mm-hmm.
Do you have any recommendations for getting started with that process, or any takeaways or key learnings that kind of have came about as you're starting to incorporate those elements?
Well, the thought behind it is that, like if a patient's being seen in the office and there's two positives, that, wouldn't it be easier to just write while you're with the patient to give them a resource? Each office has generally resource centers to meet the patient where they're at. In the build of it, we're currently in the build of that auto adjust, so that it would auto adjust the risk score and place it on the care manager's reporting. Of course, we work with the patient during transition and would address it at that time as well. But we haven't had too many issues yet. They are going to do a soft reporting to see what the volume is. In terms of if there are a lot of referrals, we have one centralized social worker that could be a problem. Like I said, it's in the development, and we're kind of working that out. We're doing some soft fire of data to see what the volume is in terms of the number of referrals when we do identify these SUH variables at that practice level. And so I guess more information to follow as we move into 2024 in the final development. I don't know if it answers your question or not, but.
No, it definitely does. Thank you. Awesome. We have a little bit of time left. If anyone else has any other questions for Kara or Kathy? I am interested, does anyone on the call have any similar transitions of care processes or procedures that they've implemented or are starting to implement that you would like to share?
It's always interesting to share with other organizations because what we found from our shared governance groups and, connecting with other organizations through the state, it's always good to share ideas and workflows. And so anytime any of you, are wondering, about what we do, please feel free to reach out. Kara and I are always open to working with others.
Well, thank you so much, Kathy. Definitely extremely important sharing knowledge. We do have a comment from Ronnie Richards. Holland Hospital has a care transitions team and transitional heart failure program, and they are hoping to present in 2024, hopefully in June.
Awesome.
To that, Ronnie.
Okay, cool.
And then Jacqueline Evans, MyMichigan is a leader in this arena. For sure. This is awesome work. Thank you so much again for willing to present your work. I will go ahead, if no one else has any other questions, and bring up my screen to conclude the work group. As I'm doing this, just as a reminder, the slides and the recording will be shared following the work group, likely this afternoon. I'll send out an email. And then, Kathy, I will make sure that I include the hyperlinks to those resources, that everyone can see those as well. So I just wanted to review a few upcoming events before we conclude for today. Thank you again for joining us, and thank you to Kara and Kathy for presenting. In January, we have 2 work groups coming up. We have a Health and Action work group on January 9th from 12 to 1 p.m. That is going to feature Trinity Health and focus on the Trinity Health's inpatient readmissions risk assessment tool. And then later in January, we have a sepsis work group, and that is going to feature some representatives from the Michigan Hospital Medicine and Safety Consortium, and that is going to highlight an update on HMS's work and sepsis toolkit. So without further ado, thank you again for joining us today. We've done the presentation informative and helpful. I will be sending out the resources this afternoon. As always, if you have any questions, please reach out to us. And I hope that everyone has a great rest of your day. Thank you again.
Thank you.
Thank you much.
Bye.